Okay, so let's talk about cluster headaches. Cluster headaches, very severe, come on very abruptly, acute. Again, the classic word here, very sharp, stabbing. You can also see this word used with trigeminal neuralgia, so not pathognomonic or anything like that. They're unilateral, just like migraines, but they're usually going to be periorbital. The patient's going to say they have pain kind of behind the orbit or behind the eye, or it could be in the temporal region as well. Okay, so periorbital, temporal headache. And whenever I think cluster, I'm just thinking about the eye. The reason I'm thinking about the eye is because classically these patients will have lacrimation, they'll have meiosis. Sometimes they'll say that this is a partial Horner syndrome. Okay, remember your Horner syndrome is going to be meiosis, ptosis, and hydrosis. So these patients, they can have the meiosis, they can have ptosis, but they usually will not have the inability to sweat, being the anhidrosis. Okay, so sometimes that's also used. But again, I think about the eye because we have the periorbital pain, we have the lacrimation, we have the meiosis. You can also see other autonomic findings here, rhinorrhea, nasal congestion. Okay, so there's some symptoms, but it's ipsilateral. It's on the side of the pain. Okay, so again, this is all one-sided, unlike tension headaches, which are bilateral. So how do you distinguish this then from migraines? Well, one thing is there's almost never going to be an aura. Okay, they're not going to have the scintillating scotomas, and they're not going to have, vision changes or visual disturbances or, left arm numbness prior to having a headache. Okay, so it's going to be a little different in that regard. The other thing is the duration is going to be very short. This is very important, not for tension headaches, but for migraines and differentiating cluster headaches. Cluster headaches, less than 3 hours. Migraines, what do we say, 4 to 72 hours. So there's a big difference here in the duration. So cluster headaches, think of them as coming in a cluster, right? You can have a whole bunch of them, multiple attacks per day potentially. And usually these clusters will have a cyclical association so that, you might always have a cluster headache every night at 8 p.m. Okay, so there's almost like a temporal association, a cyclical association, okay, which also differentiates them from migraines. And again, that's right here in the name, right? So if you can remember that they come in clusters, right? They have a very short duration as opposed to migraines. Clustered in similar times daily. You can even have them during the sleep. Sometimes the patient will wake up nightly, right? Because they're having cluster headaches. Now, the other thing is, in a board question, when you have a patient that has migraines, they're going to tell you, the patient prefers to be in a dimly lit room. Maybe they have photophobia. But a patient with a cluster headache, these patients will be, running around the room, pacing, restlessly because they're in such excruciating pain. So these patients won't be sitting still in a dark room. They'll be up and moving around usually in a board question. And the other thing is, if they're going to ask you a question about cluster headache and migraine and you're really, you're trying to put the pieces together, but you can't remember, just look, is it a male or female they're asking about? Because usually if it's a cluster headache question, it's usually in men. It's very unlikely it would be in a woman, and a migraine question is typically in females. So it also kind of use that to make your decision if you're really stuck. Okay, tobacco use is a big association with cluster headaches. About 80% of patients that have cluster headaches typically will, have some form of tobacco use. Okay, so that's particularly high yield. Usually they'll tell you the patient's a smoker or something like that. And plus or minus on the genetic predisposition, not as high yield. That's really big just for migraines. If they have a family history, I start to think a little bit about migraines. Okay, so looking at the management here, 100% oxygen is definitely a go-to for the acute management to, if a patient is actively having a cluster headache. The other thing is we have our sumatriptan again. So similar mechanism here, right? Inhibition of CGRP, vasoconstriction. And the pathophysiology of cluster headaches is not particularly high yield. The pathophysiology to remember is that of migraines. But sumatriptan again can also be used to help abort some of these cluster headaches. Even though the sumatriptan is the same, the preventative management, like I said, is going to be different from migraines, okay? So the preventative management, again, not particularly high yield for step one, but it does come up occasionally. Just to remember that this is going to be verapamil is the very classic preventative agent. If a patient has a history of cluster headaches, verapamil, being a calcium channel blocker, is usually going to be your go-to option for preventative therapy.